It's about 5:20 a.m. and me and my boyfriend are gonna head to the gym. Someone was asking about the differences with CRNAs versus CAs, so I wanted to make a video to show what my day is like again and review some of those differences. So if you're interested in that, keep on watching, and otherwise have a great day. See ya. So every morning I have a game plan with my anesthesiologist on what kind of anesthetic we're going to be doing for the case. And this case will be general anesthesia, and I will be using an endotracheal tube. I'm going to put that all together now. I'm always checking to make sure that my light handle is working, because if it's not working I won't be able to see the vocal cords when I'm putting in the endotracheal tube, and that could be dangerous. So since it's not working, I replaced it and that was good to go. Next thing I'll be doing is putting together the endotracheal tube. And I want to make sure that my connector that is on the endotracheal tube is nice and firm. That's going to be connecting to the circuit. And I also need to check that the cuff is working. So I got a 10cc syringe and now I'm going to inflate the cuff. I'm going to make sure that it does not deflate with pressure and it holds up, which is what I want. I'll also be putting in this stylet and I'll be shaping the endotracheal tube into hockey stick kind of shape, because that will align with the oral tissue so that I can place the endotracheal tube. And everything is good to go, so I'm going to put that down on my tabletop. I'm going to get a few pieces of tape because that's what I'm going to use to secure the endotracheal tube. So for the kind of case that I'm doing today, I'm going to be using a breathing tube, aka an endotracheal tube. And then this cuff right here makes sure that the lungs are protected from any food going back in. And we do that for certain kind of procedures like laparoscopic procedures. And then this here has a light at the end of it, and it will show the vocal cords, and that'll help us place the breathing device when we need to. So hold it like this, like that. You're lifting up and away essentially to make space for you to put in the breathing tube and for you to see everything. So you put that in, someone will take out this stylet at that time, and then you'll also inflate the cuff with this 10cc syringe. So this is an oral airway which will help with bag mask ventilation, and this is done before the breathing tube gets in. Then this is to secure the breathing tube, and this I usually use for the eyes, but in case I want it extra secured, I'll put this over the pink tape, kind of anchor it more. Again, this is the blade, and it lifts up the oral tissue so that you can see everything, and it also has that light on the end. So you always check every day to make sure that this light works, because you don't want to find out as you're putting in the breathing tube that this doesn't work, and then you have to switch it out, and just puts the patient at risk essentially for not having oxygen getting to their brain and things like that. So you want to make sure that this is always working every day. You always check for the integrity of this cuff right here, and I already did that using this 10cc syringe. This stylet is to help place the breathing device. This here is a temperature probe, and we'll be monitoring the temperature the whole time. And we also put this, which is a warming blanket, and it connects to hot air, and that keeps patients warm. And then this is to suction out the stomach and remove excess fluids and things like that. Although the patient may still have food in their stomach, at least it removes some of the volume. If the patient had any sort of risk of that volume getting into their lungs, at least we have reduced it with this OG tube. You lubricate both of these just to make it easier to put it into the mouth and not cause as much trauma and make it smoother. That is what I like to set up every day. I also checked for my SIVO to make sure that there's enough. Checking for the CO2 absorber to make sure it's not all purple, but sometimes it will actually be completely used up, and then you'll see it later on in the case. And then here's our suction. I made sure that worked as well. And we have this ambu bag back here in case something goes wrong with the machine. We always have this extra backup to be able to ventilate the patient if something happens to the machine. So now I'm going to be getting a couple of syringes ready. I'm going to get a syringe for Versed. Versed is an anxiolytic, so it will relax the patient. They will also get fentanyl, which is a pain medicine. They will get propofol, which will be the agent to put them to sleep. And they will also get rocuronium, which is a paralytic. I also have a syringe ready for phenylephrine in case their blood pressure drops during the case. There is something to bring it back up to normal limits.
case, the patient had an MPO status of over 8 hours, meaning they did not eat or drink anything within the last 8 hours, putting them at low risk of aspiration, which means that they would have a low risk of food or fluid getting into their lungs. The surgery would be very quick, the anesthesia was going to be general, and the surgeon did not require paralytic. Because of all these considerations, we considered an LMA over an endotracheal tube for the airway device. Comparing an LMA to an endotracheal tube, an LMA does not go into the trachea, and it will not protect the lungs from any food or fluid from getting into the lungs. However, it is very quick to place. It has less incidences of sore throats because it does not go into the trachea, and patients tend to be more hemodynamically stable with an LMA versus an endotracheal tube. So we thought an LMA would be a good choice for this anesthetic and for this patient. Around the end of my shift, I was giving out lunch breaks. So my coworker was doing a TIVA case for a neuro case. So she was doing remifentanil and she was doing propofol for the TIVA. And she was monitoring the depth of the anesthetic with a Viz monitor.
So I wanted to address a couple of talking points about CAAs versus CRNAs. I've worked with CRNAs and I've worked with anesthesiologists, and overall my relationships with them have been very positive. In terms of anesthesia providers in the US, there are physicians. So there are physicians that are currently in residency or fellowship. There are other physicians that have already graduated those programs and are now attending physicians. There are CAAs and there are CRNAs. There are also dental anesthesiologists who provide anesthesia for
Oral maxillofacial surgery.
In those three anesthesia providers, there's a couple of anesthesia teams or anesthesia providing models. So there are anesthesiologist only practices, there are CRNA only practices, and then there are practices that have anesthesiologists overseeing CAAs, CRNAs, and residents or fellows. And that practice is called the ACT model, the anesthesia care model. And with that practice, the anesthesiologist will be overseeing usually 3 to 4 rooms at a time, and CAAs and CRNAs will be in the rooms providing anesthesia and being with the patient the whole time, and the anesthesiologist will be there for important times of the anesthesia care. They'll be there for induction, placing the breathing device. They'll be there for emergence. They'll check in if it's a case that might need blood, a case that might need arterial lines, different kinds of procedures or certain kinds of blocks. Usually anesthesiologists will be present for those kind of things. It's usually in these kind of cases, the CAAs, CRNAs again, are with the patient the whole time. So that's the kind of model that I'm in. I'm in an ACT model. And day-to-day responsibilities, overall, it seems like if you're in an anesthesiologist only practice, CRNA only practice, or in the ACT model, overall, the day-to-day responsibilities are very similar. I meet patients, I do an assessment. My anesthesiologist will also meet them and assess them. I'll do my anesthesia plan. I'll also discuss with my attending, make sure that the plan is what we both agree on. Then we'll induce the patient, place a breathing device. My anesthesiologists definitely foster independence, so I'm not completely leaning on their judgment. I also have my own judgment, and that's the same in other practices, and CRNAs and anesthesiologists will also do that. They'll use their judgment in terms of the anesthetic plan. So we'll come to an agreement on the plan, induce the patient, place a breathing device, monitor their vital signs throughout the procedure, and then afterwards they'll wake up, we'll drop them off, give the report to the receiving nurse, and repeat that process over a few times. Also in my job, I chart. I help other people with charting, or I'll give other people breaks. Again, very similar to what a CRNA or an anesthesiologist could do in anesthesiologist and CRNA only practices. So that's just something to break down. As you can see, my day is very similar. I'm setting up my room, I'm meeting patients, I'm placing breathing devices, I'm administering medications, monitoring the patient, treating pressures, helping them wake up and helping them breathe on their own when the procedure's over, transferring the care over to a nurse at the end. So very, very similar to what a CRNA might do in their day-to-day responsibilities. There are practices that are CRNA only practices that have billing that allows for that, versus there are no CAA only practices. CAAs always work under the ACT model, working with anesthesiologists. Personally, I really like it that way. I do like having an anesthesiologist that I can ask for questions. Anesthesiologists have residency behind their training, so I think that's a great resource, and why not maximize your resources? These articles show the evidence for physician-led anesthesia care. This article examines the idea that physician-led care is more costly. Not only were surgical outcomes improved, lives saved, but costs were also reduced by reducing the amount of unnecessary tests and unnecessary surgical cancellations. This article supports anesthesia care teams that have anesthesiologist assistants in them. In this study of 443,000 patients, there were comparisons of ACT models that had CAAs versus CRNAs. And in the ACT model with CAAs, the adjusted mortality rate was very similar to the mortality rate for nurse anesthetists in the ACT model. This article states that even with differences in the composition of the anesthesia care team, the outcomes were very similar and not statistically different. Something else to consider is working in all 50 states. A common misconception about CAAs that we can't work in every state, because we can. We work under the Veteran Affairs billing, and there is legislation that allows for CAAs to work in all the states under the Veteran Affairs billing. CAAs can work in all 50 states, however, not at the same capacity that other anesthesia providers work, for example, anesthesiologists and CRNAs. So that's something to consider if you're looking into the CAA versus CRNA profession. It's two different paths to consider as well, because if you're on the nursing route, it makes sense to get your ICU experience and go into the CRNA. If you're a nurse and you want to go either route, the CAA route is also open to you. For me, I had the prerequisites to go into medical school, and I was heavily considering that. And then I learned about this profession, and I decided that this was worth it for me. I'm very happy with what I chose. Again, my working relationships with CRNAs and anesthesiologists have all been great. There hasn't been any issue. So that's kind of what worked for me, and everyone has to figure out their own situation. Keep an open mind when you're looking into both professions.